Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the NICU. And today we are going to be covering conventional ventilation in the NICU. My goal today is to kind of go through conventional ventilation. We're going to talk about 4 main different ventilation modes. We're going to talk about what you might want to adjust in those modes based on some values you're seeing. Those are additions to the slide, so we're going to talk through that. I'm going to show you my cool drawing that is bigger here, and we'll kind of talk through that. But overall, this is to give you a slightly deeper understanding of conventional ventilation, what babies it is best for, and when we might need to escalate to another form of ventilation. So let's review. We know that ventilation is, first of all, the single most important step of NRP, but we know how important it is for our babies, especially those premature babies who are born with those underdeveloped lungs and are at high risk for respiratory distress and other complications. We know now, here in 2024, that there is a risk of overventilation, that if we give babies too big of breaths, too frequent of breaths that are kind of going against what they need, we have an opportunity to actually do some damage to their lungs. And long term, that can cause that phrase, either chronic lung disease or bronchopulmonary dysplasia. Even these big swings in ventilation can increase a baby's risk for IVH. So we want to make sure that we are giving them what they need, but not too much. We think of this like a balloon. If you go on YouTube, there are great videos that show kind of this balloon expanding and contracting with a ventilator. It's super helpful. But if that's kind of what we think of the lung, or even at a smaller level, the alveoli, we want that balloon to expand enough that we're not overstretching it, because once a balloon's overstretched, it's hard to ever kind of get it back into its elasticity. And we don't want to stretch it so much that it pops. So that's kind of what we're thinking about, is this balloon that's not all the way inflated and not all the way deflated when we kind of talk through these modes of ventilation. So let's talk about our 2 most common forms of ventilation that you can kind of see everywhere. And we're going to look at these pictures bigger on the next slide. But first, let's talk about synchronized intermittent mechanical ventilation, or SIMV. SIMV is primarily used in 2 different modes: volume control and pressure control. So when we think of that, we want to think about the volume control is that the vent is going to give a set rate, a set volume, and an inspiratory time. So that says, hey, every time the vent initiates this breath, it's going to be this size, and it's going to be this much volume going in, usually 4 to 6 milliliters per kilogram, and it's going to be the set inspiratory time. Now, a baby can initiate a breath all they want. If they do, they get to kind of determine their own volume instead of taking that volume that the vent is set at. In this mode, you can add a pressure support so that when the baby does take their own breaths, we're saying, hey, we're going to make sure at a base it's going to be this much. So it is a gentle mode of ventilation. It does allow babies to synchronize. That's where this SIMV comes in, their own breath within there, instead of saying, hey, even if you initiate, we're going to give you this. It's saying, like, let's let the baby do a little bit of the driving. Pressure control SIMV is the same thing, but instead of a set volume, you have a set pressure. So think of that as your PIP. Remember, PIP is peak inspiratory pressure. Your PEEP is peak and positive and expiratory pressure. So when we think of our pressure control SIMV, it's saying every single time we're going to take a PIP of 21, 21, 21, 21. In this mode, it only does that when the vent initiates the breath. When the baby initiates the breath, again, they get to kind of be their own driver. And again, you can have a pressure support attached there. So let's look at these little drawings a little bit more in depth. First, my beautiful handwriting. I know how much we all love my beautiful handwriting. At the top, we have our volume control. So what you can see set there is that we have a volume control of 4 to 6 mils per kilogram. That is the most common range of volume for ventilation. We're going to do this easy. We're going to say the baby's set at 5 per kilo and the baby weighs a kilo, because let's make this easy on ourselves. So that means every single time the volume that's going into the baby's lungs is going to be 5. And depending on their lung compliance, the PIP is going to vary. Sometimes it might take a little breath, like this 18. Maybe they're nice and relaxed, and sometimes they're almost fighting it, and it's going to get up here to a pip of 30. So you can see that, hey, we need the same volume, but sometimes it's going to be this big push out and kind of that expansion of the alveoli. And that could be, it needs to have a variation in the pip because not all the alveoli are working equally together. And so we're trying to aerate into all of the lung, and so that's where we're going there. So this volume control, your pip is your variable because you are setting your volume. So within this example, we see that our pips have been anywhere from 18 to 30. That's a pretty wide variety. When you are in pressure control, you are saying every single time we are going to hit 25 over 5, 25 over 6, whatever your PEEP is going to be. So your PIP is 25. So you can see that here. We have a PIP set to 25. And your PEEP's probably 5 in this example. But within that, like, hey, I'm doing this, but I might only get a little bit of volume as small as a 2. I could get a volume as big as a 5. Honestly, we've seen volume sometimes 8 and 9, and that means like it's going into those bronchioles, into the alveoli, into the smallest little bud of the lung, and this big volume. And so you can see that the volume is your variable. So when you're trying to see like how is the baby doing, I always think, you know, when we're reviewing, so if you're documenting as the bedside nurse and you're documenting the variable and you document the PIP, if your baby's constantly hitting a PIP of 30 in the volume control mode to get their volume, you might think to yourself, ooh, are we giving the baby too much volume that's giving them these really big breaths? Could we consider lowering our volume? Are they needing such a big PIP and they're still not meeting that volume that we've set? Maybe it's not, you're kind of getting that, you know, volume not met kind of alarm. Maybe they're not doing well in this mode of ventilation. If you're on pressure control and they're taking, again, you're hitting your PIP of 25, but you're getting giant volumes, 8, 9 per kilo, maybe we could drop that PIP down because we don't want to be giving them such big breaths. So it is super important to pay attention to your variables and to kind of know what your baby has been trending at. Because remember, one value doesn't tell us anything about a baby, just like one blood gas is only capturing what that baby is doing in that moment. Something like this, you can go back on your vent screens and see, hey, what were they doing? What was their trends like over the last hour? It's going to tell you so much about their lung compliance. Highly recommend looking at that. So SIMV and your pressure control or volume control are 2 of our most common types of ventilator modes that you will see in the NICU for premature babies. Those with respiratory distress syndrome, babies that maybe are getting intubated for a surgery. It could be an older baby, a baby with TTN, a baby that is like a late preterm that just needs to get a little bit of gentle ventilation while they're maybe getting some surfactant. This is going to be a great mode for you. Now, some of our more common, other common forms of ventilation are the assist controls. These are kind of more, I always think that the vent is in most control in these modes. And that's kind of saying that the baby in and of themselves can't do that much. So you might actually see this mode a lot if your baby is sedated, whether that is for surgery, if for lung compliance, on a premature baby who is very apneic and not initiating their own breaths. So on volume control, assist control, VCAC, there's a set rate and volume every single breath. If the baby initiates the breath, we're still saying, hey, you got to take this much. And in fact, sometimes it looks like the breaths are almost stacking because of how frequently the baby might be trying to take a breath with what the vent is doing. It does use the least amount of pressure to hit the volume, and it can be good in those initial ventilations. In my previous facility, we use AC mode a lot. This was a very common thing that we would do in our micro premature babies. On admission, we would put them on this, and it's just really like the vent is driving this mode of ventilation. So pressure control, assist control is similar. We're trying to set a pressure to give that baby the same amount of volume, but we're saying we want to do it in a pressure mode, not a volume mode. So if the baby breathes or the vent is initiating the breath, it's the same amount of pressure. So if I were to just like kind of give you a clear cut, SIMV mode is more baby driven and AC mode is more vent driven. Does that make sense? Okay. So let's look at our values. So what's super important here to think about, again, is what has the baby been trending? One TCOM of 70 tells us nothing. Maybe you just finished cares, maybe reposition, maybe we put the baby back after kangaroo care. Let them settle. But if you're seeing a steady climb, that's when we would kind of be like, hey, what's going on here? So let's talk about some things that we could adjust. So if our CO2 is high and we are in a pressure mode, either one, any sort of pressure mode, if your CO2 is high, we could increase the pressure or the rate. So we give them bigger breaths, give them more frequently, etc. If you're in volume mode, we'll change the color here, and your CO2 is high, it's going to be similar. You're going to increase your tidal volume or your rate. So remember that the rate is the set rate. So that means that maybe your baby is not really initiating that many breaths and you're on a set rate of 40. Maybe we need to go up to 45. So it's important to remember that the kind of opposite would be true, right? If your CO2s are low, you're going to decrease your PIP, you're going to decrease your rate. If your baby is breathing way over your vent rate, decreasing your rate doesn't actually do as much as you think it would. So it'd be, hey, do we need to decrease our pressure? Do we need to change to a volume mode, etc. If your pHs are changing, again, you want to see, go back to our blood gas. Remember we did our 4-part series on blood gases. Go back and look, what is that pH doing, and is it metabolic acidosis, respiratory acidosis, and then decide what you're going to change based on that. If you are having rising CO2s because we're trying to keep our SpO2 above 90, it is also something we need to look into. That's probably where I would also be wanting an X-ray. I think when we think about our SpO2 and our O2, is our tube in the right place? That's beautiful handwriting. Is our tube in the right place? Has one of our lungs collapsed? Do we have a pneumothorax? How are we aerated? Have we de-recruited and now we're requiring all this oxygen to kind of get us going there? I think especially if you have high O2 requirements out of nowhere and your CO2 isn't rising as quickly, when your CO2 is high and you have high O2 requirements, high needs, then you're like, okay, there's probably a lot going on here. But if your O2 is just going up, sometimes that makes you really think about a dislodged tube because the baby could be doing a lot on their own that's keeping their CO2 in a safe place. So let's look at some of those x-rays. These are just two very generic views of an x-ray. In our top one, we have what we would call that whiteout. Remember, in x-ray, air is black. So we want to be able to see this kind of black through there to know that we have air in all these places. There's this over distension. If we were to count the ribs, right, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 almost. Our diaphragm is almost flat. We don't want our lungs to be so expanded that we've flattened our diaphragm out. Those are all risks for that chronic lung disease, that bronchopulmonary dysplasia we were talking about. The tube, almost like maybe it's hitting this carina here, so how well is the air getting in? Again, I am not a radiologist, so take this with your own grain of salt. What maybe we need to do is pull our tube back a little bit. Do we need some surfactant to get in here and get these alveoli lubricated? Do we need to switch to volume? Maybe we've pressured out and pushed our lungs out too much, so we need to go to a volume-driven mode. Down here, you're going to see maybe a more severe form of RDS because over here, one lung is not expanded at all, and then we've got this kind of well-expanded, well-aerated middle lobe. So you kind of think to yourself, is there a clog in your tube? Did our surfactant only go on one side? Do we need more surfactant? Do we need to change our mode of ventilation so that we can get into this lung? If one of our lungs is poorly aerated, you want to position that lung up, okay? So on this side, it is the baby's left lung. The left lung is poorly aerated, so we did want to put the baby on their right side with that left lung up because remember, air is going to rise. It's the path of least resistance, so we're going to get more air driven into that lung. And so that would be something else we could consider for this x-ray. Again, not a radiologist. How else do we help our babies? So supplemental therapies we use when a baby is on conventional ventilation include medications such as caffeine, surfactant, steroids, and diuretics. Without a doubt, I would say caffeine is like the single most used medication in the NICU. It's got to be up there, maybe besides sucrose. But caffeine stimulates that respiratory in the center of the infant's brain to remind the lungs to breathe because we are not meant to be doing that at 23, 24, 25 weeks, up until even 34 weeks. Surfactant is a lubricant, right? It reduces the surface tension and it helps maximize the surface area for gas exchange. So if you have high CO2 levels, poor aeration like in those x-rays, you might need some surfactant. Steroids tend to be a little bit more controversial. They're not used as any part of initial therapies. This is more if a baby's been stuck on the vent for a long period of time. And same thing with diuretics. We don't jump to diuretics or steroids like we would caffeine or surfactant. Diuretics are kind of helping keep fluid off the lungs and trying to keep those lungs from being too inflamed, which also speaks to our surgical intervention that helps with respiratory, which is a PDA ligation. So its goal is to stop the abnormal blood flow and hopefully reduce pulmonary overcirculation. It may help normalize lung function. So we've talked about our circulation, right? Our antenatal and postnatal circulation and the way the circuits work in there. So there's an old video you can go back and watch. But anytime that you're kind of pushing unoxygenated and oxygenated blood back into the lungs are going to have too much blood flow. They become inflamed. They can't do their job well. They can't differentiate between the two. So it just isn't as good for them, and it increases their respiratory disease and their inflammation. It also, the goal with the PDA ligation would be to enhance the effectiveness of the mechanical ventilation so that we could get these babies extubated, because ultimately that's the goal. Days off the ventilator when the baby has to use their muscles to breathe is lung growth. So days off ventilator is going to equal lung growth faster than days on the ventilator. So always keep that in mind. We have so many therapies in the NICU that have drawbacks, and ventilation is one of them, because we are giving them something that they need, but also is causing damage. So the least amount of time we can give them this thing that they need, the less damage we're going to do. So how can we help get them off? So let's talk about what happens when our conventional ventilation has kind of reached its maximum. And the idea there is we have put our pressure up, right? We kind of have pressure limits. So if we're in pressure control mode and we are at pressures of 25 to 30, we know we can't really go any further. We have rising TCOMs. If we're on ventilation mode and we're over 6 per kilo, maybe we've tried 6.5 per kilo and we're just kind of over that, we might need to switch to a high frequency ventilation. So we have two choices, which would be the oscillator or the jet. And next week's Teach Me Tuesday is all about high frequency ventilation, so tune back in for that. But with high frequency oscillating ventilator, you have an active inhalation and an active exhalation happening at 300 to 900 breaths per minute. That's what your Hertz is, and we'll dive into what all that means. And on the jet is actually short bursts. So in between bursts is when there's kind of this passive exhalation going. So still, again, very fast breathing, and we'll go into kind of all of that and what the difference is between those two things. So of course our parents see this thing, right, the ventilator, and it's so scary, and especially if the baby is a tiny little micro preemie like the one in this picture, and they have this big ventilator kind of coming in and doing all of these things, and we say all these words like, oh, the pressure and the volume and the rate and their CO2, like, whew, that's so overwhelming. So basically we're just want to give them plain language to understand what we're doing. We're giving the baby a helping hand. We're giving those underdeveloped lungs that weren't prepared to have to work outside the womb yet this opportunity to breathe in a safe and controlled manner. What we don't want them to do is to be so scared that they don't want to touch their baby or do kangaroo care or change diapers or participate, because we need them. We need them to be a big part of this care team, and we need them to be able to provide all those things for their baby. So encouraging them to the bedside, getting the baby out to hold to kangaroo, telling them that hopefully this is going to be a temporary intervention, that we have room to continue to increase as needed, etc. Explaining, showing them what the alarms mean. I always think there's such power in understanding the alarms and the noises that they're hearing around them. So giving them that power as well. So really when we think about this conventional ventilation, we use it to support the respiratory needs of these premature babies, to get rid of oxygen and to bring in to get rid of carbon dioxide and bring in oxygen, to reduce the effort of the baby so we can have proper lung development, to use the least amount of ventilation that we need to avoid those complications. We want to tailor this to, the individual needs of the baby. And I remember hearing that once in a lecture, that what seems like a mode that works on every premature baby is probably not true, because we know there's no such thing as black and white in the NICU, and we have to find that gray that might be perfect for this baby. So doing that, along with encouraging our parents to be there and provide kangaroo care and to participate at the bedside, are going to be the strategies that we need to use and to implement in our NICUs to have good outcomes and to get the babies extubated. Thank you for joining me today for conventional ventilation, and I will see you next week where we will talk about high frequency ventilation.